Hello everyone. It's really a great pleasure to talk to you today about one of the most important subjects in medicine and in health in the world. May sound exaggerated, but I really want to challenge you to listen to the whole of this video and you'll see exactly what I mean. So we're going to get right into it, but before we do, please press that subscribe button and the bell. If you like what you see, I would really appreciate it if you add a like as well.
Anemia affects 2 billion individuals around the world, and of these, iron deficiency anemia alone is responsible for about 1.24 billion cases. Now, as you can see here, of all anemias, both in men and in women, more than 50% of anemia cases are due to iron deficiency. It is currently the leading contributor to the global burden of disease. 2 to 4 billion people may be iron deficient, even if they're not yet anemic. It's the most common micronutrient deficiency worldwide, the #1 cause of anemia, and the most common hematological complication during pregnancy. And from an economic impact point of view, it has been estimated that a global investment of about $70 billion will be required globally to mitigate the impact of anemia over the next 10 years. The focus of this talk will be on iron metabolism and its application to the clinical features, diagnosis, and treatment of these patients. If you understand iron metabolism, and I hope to make it a bit easier for you, you can easily understand all these other elements of the condition. These are the major steps in iron metabolism: intake, absorption, transport, utilization, recycling, storage, and loss. And we will go through these one by one. Let's start with iron intake. The intake of iron is important not only with regards the amount of iron you take in, but also the form in which you take in iron. In a normal Western diet, we take in about 10 to 20 milligrams of iron per day in the forms of either heme iron, as found in meat, poultry, and fish, or as inorganic iron, as found in meat and vegetables. Now, the first step of iron metabolism regarding that which you take in is removing the iron from the food in the stomach, and this is done by hydrochloric acid in the gastric fluid. And very important, because if you do not have an adequate amount of hydrochloric acid, such as in patients who've had a gastrectomy, if a patient has atrophic gastritis, as in the elderly, very commonly, or in pernicious anemia, or if the patient takes a proton pump inhibitor, all of these will lead to very poor iron absorption due to decreased hydrochloric acid production. The next step is iron absorption. We said that a normal Western diet consists of about 10 to 20 milligrams of iron in the food that you take in per day. But it is important to note that it's not just, as I said before, the amount, but also the form in which you take in iron. As an example, iron is much better absorbed in the heme form, which is found in meat, poultry, and fish. About 30% of that iron can be taken up by the body, whereas the inorganic form found in meat and vegetables is very poorly absorbed. You can see here that of the 10 to 20 milligrams of iron taken in the diet per day, only about 10% in total, 1 to 2 milligrams, is absorbed into the bloodstream. And there are numerous factors that can affect iron uptake in the duodenum where the iron is absorbed. On this slide, one can see that the amount of iron differs greatly between different foods, and this sometimes leads to misunderstandings. We are often told that spinach is a good source of iron, and as you can see here, spinach does contain a lot of iron, but only 1.7% of that iron is actually absorbed. So how much spinach do you need for your daily needs? Well, if you calculate how much iron there would be in 100 grams of spinach, and you look at the percentage absorbed, you actually need between 2 and 4.5 kilograms of spinach every single day. So it is not good advice to tell a patient to eat more spinach because they will never be able to take in enough. What is important to notice here then is that vegetarians, vegans, and those with a low meat intake are at risk of iron deficiency. There are other factors that can also affect the absorption of iron, specifically in food. For instance, iron is poorly absorbed when you take it with certain other types of food. So for instance, if a patient is taking an iron supplement with a typical continental type breakfast containing cereal and bread, or calcium containing foods such as milk or calcium supplements, maybe with eggs, tea and coffee, all of those will decrease iron absorption significantly. So it's important to know whether the iron that you prescribe to your patient should be taken on an empty stomach or whether the formulation can actually be taken with food, and there are examples of both. Tea and coffee can decrease iron absorption by about 50%, so it is best to keep tea and coffee for tea time. I don't tell my patients that they cannot drink tea. I only tell them not to take the tea or coffee with their iron supplementation. Then there are factors affecting the uptake of iron on the other side, on the circulation side of the duodenum. These may be factors such as surgery, where part of the small bowel has been removed, as in bariatric surgery, where there are diseases of the small bowel, such as celiac disease or inflammatory bowel disease, or any other disease such as inflammation or cancer, infection, renal failure, where you have anemia of chronic disease and a blockage of iron absorption by a hormone called hepcidin. And a little later, I'm going to tell you more about this. The next step in iron absorption is iron transport, and this one is very important to understand because it helps you with understanding the diagnosis of iron deficiency, sometimes in difficult cases where there may also be inflammation present. But let's start with the basics. So iron is carried around in the bloodstream by this molecule called transferrin, trans for transport, the ferrin part referring to the iron, and I like to think of it as a little two-seater canoe. You can see that there's space on transferrin for 2 iron atoms. Once absorbed through the duodenum into the bloodstream, transferrin carries iron around to the bone marrow where it is needed, and of course to all other places where it may be required. And we measure iron in the circulation or in the transport system as so-called total iron binding capacity or transferrin saturation. Now these terms have been very confusing to many people, and I'm going to explain them now so that they will hopefully become very easy for your future purposes. Just note that about 1/3 of the seats on these two-seater canoes called transferrin are saturated with iron in healthy, normal people. So let's use the example, or start with an example of, imagine that you've got 5 of these canoes, each with 2 little seats. Question is, what is the total iron binding capacity? Well, there are 10 seats. So the capacity of the transport system to carry iron passengers is 10. That's your total iron binding capacity. In this example, 4 of the seats are filled with passengers. So your serum iron is 4. So what is your transference saturation? Or let's say, what is the saturation of your transport system? By put all of this together, we can see that the serum iron is 4, the binding capacity is 10, which means that the percentage of seats that are filled with iron is 40%, and that is what we call the transferrin saturation. This is completely normal, normal being between 20 and 50%. Here is another example. In this case, we can see that we still have 10 seats, but only 1 iron on a seat, which means that the transferrin saturation is now going to be much lower because less seats are taken. We repeat our calculation, you can see the saturation is now 1 in 10 or 10%. So as a rule of thumb, you can say that transferrin saturation below 20% would be considered as low. Our next step in our iron metabolism pathway is iron utilization. Now, of course, the bone marrow, being the factory of red blood cells and other blood cells, is the primary place where iron will be delivered to make red blood cells, and 50% of the total body iron is actually found inside red cells. You can see here that 200 billion red cells are produced every day as iron is incorporated into hemoglobin. What is not often recognized is that the rest of the iron is needed in every single cell of the body, the heart, the brain, the muscle, the fetus, any cell in the body, to produce ATP, which is your primary energy molecule. And you need iron in many different steps of ATP production. I will come back to that, but let's go to our next step first, iron recycling. So once the red cells are produced in the bone marrow, they move into the circulation and will spend more or less 120 days going around, after which they will be old and in need of recycling. This happens in the bone marrow, where the macrophages will eat them, as they will not be able to pass through the spleen's testing ground for flexibility and for youthfulness and health. And the macrophages will basically recycle all the components of the red cell, including the iron. And you can see here that of the iron in the circulation, most of it actually comes from recycled red cells. You remember we said earlier that 1 to 2 milligrams of iron per day comes from the absorption in the duodenum, and 20 to 25 milligrams of iron per day comes from recycling in the spleen. This brings us to our next step, which is iron storage, and this takes place in the liver in molecules, specialized molecules called ferritin. And you can just hear by the word tin that we're talking about a storage container. But ferritin is also a very useful measure of iron stores, whether they are low or whether they are high. Unfortunately, the difficulty with ferritin, of course, is that it is also an acute phase protein. and can increase in other situations such as infection, inflammation, or liver disease. So we need to account for that. A very useful tip is that if you look at your ferritin value in nanograms per mole, 1 nanogram per mole of ferritin equates to about 10 milligrams of total iron stores. So in an adult male, for instance, if the male has a ferritin between 30 and 300, that means that they need about 300, or that they have about 300 to 3,000 milligrams worth of iron stores. Note that an adult female with a ferritin of 30 only has 300 milligrams of iron stores available, but needs 1,000 milligrams extra for every pregnancy. The last step in iron metabolism is iron loss. Now, the body has no way of actively excreting iron, or let's say of increasing or decreasing its iron loss. It happens passively through either the desquamation of cells from the gut that contain iron, or through menstrual blood loss. And the daily iron loss, which happens through the loss of cells from the gastrointestinal tract and skin, is on average about 1 milligram per day or 30 milligrams per month. And in a premenopausal female, they will lose an average of 16 milligrams per normal menstruation. And if you add to that the 30 milligrams they lose from the gastrointestinal tract or skin, you can see that they lose about 40 to 60 milligrams per month. So taking us back to iron absorption, we said that a normal healthy person absorbs about 1 to 2 milligrams of iron per day. That 1 milligram refers mainly to men, and the 2 milligrams especially to menstruating females. Now, how is all of this kept in balance? So the maintenance of iron homeostasis depends primarily on the control of absorption from the gastrointestinal tract, because as I said, there are very limited mechanisms of iron excretion. And it helps to understand the basics of iron absorption to understand a lot of things around iron deficiency diagnosis and also the treatment of iron deficiency anemia. And let me take you through a few steps here. So the first thing to see here is that iron in your food and also in many supplements often come in the Fe3 plus form, which is called ferric iron. The way I remember it is if you think about it, ferric sounds like 3, and ferrous or ferrous iron sounds like 2. So ferric iron is reduced by an enzyme on the surface here to Fe2 plus or ferrous iron, which is taken up by a divalent metal transporter 1 sitting here on the duodenal surface. And as you can hear from the word divalent, it can only take up 2 plus iron. The problem with Fe2 plus is that it contains an extra electron, which is very dangerous to cellular organelles. And that Fe2 plus, which is taken into the cell here, forms what is called a labile iron pool, which if left to its own devices can cause a lot of damage to the cell, its membranes, DNA, mitochondria, and organelles. So any iron that enters the cell as Fe2 plus needs to be handled very quickly and taken to safe spaces. One is ferritin. So ferritin is not only found in the liver, but also found in every cell of the body, including the duodenum, where it can be stored, or it is taken to the mitochondria for ATP production. Again, this happens in every cell of the body. And lastly, the third way is that it is taken into the circulation through this molecule called ferroportin. And you can hear from the word the ferro refers to the ferrous, the 2+, and the portin to the iron door through which it has to pass to be placed on the canoe. On this side, you can see iron in the heme form, which is taken up by a completely different mechanism, and the iron in heme is also released into this labile iron pool, and from there it is taken up through ferroportin. Now, what is the key that is responsible for locking this iron door called ferroportin? The key is hepcidin. And when hepcidin is present, when its production is high, it will lock all the ferroportin doors. And if the ferroportin is locked, iron absorption will be decreased. If hepcidin production is low, ferroportin will be open and iron absorption will be increased. Now, what is the practical application of that? Well, in situations where hepcidin is low, for instance, simple iron deficiency, or in patients with genetic or inherited conditions that lead to a low hepcidin, such as hereditary hemochromatosis, all the ferroportins will be open and iron will be absorbed very easily. So if you have a patient with iron deficiency anemia, which is a simple iron deficiency, there are no other conditions such as inflammation or cancer, hepcidin should be low and iron absorption will be easy, and you can treat such a patient quite easily with oral iron. Unfortunately, when a patient has infection or inflammation, has cancer or has recently had surgery or tissue trauma, hepcidin will be high, and the hepcidin will block the ferroportin everywhere in the body. You'll see here the ferroportin is not only in the duodenum, but also on the liver, the macrophages, which can be in the spleen or the bone marrow. And now the iron cannot be absorbed, it cannot come out of the stores, it cannot be recycled, and it is basically not available for red cell production. And that is what we call iron-restricted erythropoiesis. And in these cases, oral iron absorption is blocked, and you need to find an alternative to bypass ferroportin. And this is usually either intravenous iron or a formulation of iron that is not dependent on the ferroportin or hepcidin-mediated pathway, and there are examples such as sucrosomial iron where this is the case. So we have said to each other so far that there are important factors in iron metabolism, such as intake, uptake, and also iron. So in simple terms, what we are saying to each other, it's important to take note that intake is very important, both in terms of the form of iron and the amount. We mentioned spinach versus red meat. Red meat is a good form of iron, spinach not a good form. The uptake of iron, there are many factors in your diet and the things you drink like tea and coffee that can block absorption, as well as hepcidin in cases such as infection or inflammation. And then, of course, the last one, take out here, any blood loss will be very important to know about. How does all of this help us to diagnose iron deficiency? Now, the first important thing to know is that the classical description of iron deficiency anemia on the full blood count, which includes microcytic hypochromic red cells with low ferritin and low bone marrow iron stores, is only seen in advanced iron deficiency anemia and often not seen in the earlier phases of iron deficiency. Now recognize that iron deficiency goes through 3 different stages that are very important, each in their own right. And very important to notice is this stage 1, which is called non-anemic iron deficiency, where the patient can have low iron levels, low iron stores, but they are not anemic and the cells appear normal. Yet the patient can have all the symptoms of iron deficiency anemia, even though they're not yet anemic. In stage 2, the patient can be anemic, but the cells will still be of normal size and color. And in stage 3 only, which is, as we said, the advanced phase, you will find all the classic manifestations on the peripheral blood smear and the full blood count that is typically associated with severe iron deficiency. So here it is very important to notice that hemoglobin on its own is not adequate. In this example here, one of the studies showed that if you only use hemoglobin, then you will miss 42% of your iron deficient patients. Now, this will vary from country to country, but I think this is very true for many low middle income countries. So you need additional tests such as a serum ferritin, which is a very good screening test, but also not perfect. And sometimes you need complete iron studies such as transferrin saturation also to make sure that the patient doesn't have iron deficiency, even if the ferritin appears to be normal. So this brings us to serum ferritin and how to use it. Now, we said that ferritin is an intracellular storage protein of iron and correlates well with the body's total iron stores, but importantly, in the absence of inflammation. If you live in a country where there are lots of patients with infectious disease, inflammatory conditions, cancer, renal failure, etc., the ferritin on its own will not be enough. There's also a problem with the low cutoff values used for ferritin by many labs. For instance, many labs will report a ferritin less than 15 only as being abnormal. Your problem with that is that that has got a very low sensitivity for iron deficiency, and you will miss about 43% of cases because of the lack of sensitivity. If you use a higher cutoff, such as a ferritin of 30, you will only miss 8% of cases. More recent research suggests that you need even higher ferritin cutoffs to be accurate. But as most guidelines nowadays recommend a ferritin cutoff of 30, we will stick with that here. What do you do with patients with ferritins between 30 and 100? Well, in these cases, you have to also do the transferrin saturation. And if that is less than 20%, then you can also make a clear diagnosis of iron deficiency and treat the patient as such. So, in simplified terms, in all patients, we will do a hemoglobin and a serum ferritin as screening tests. And whether the hemoglobin is normal or low doesn't really matter. If the serum ferritin is less than 30, you will treat the patient as having iron deficiency. If the patient has a ferritin between 30 and 100 and the saturation is less than 20, you can also treat as iron deficiency, independent of whether the hemoglobin is normal or low. But if your serum ferritin is more than 100 and the SAT's less than 20, you may need more specialized tests and perhaps the help of your hematologist to make a diagnosis. Of course, we should not forget about other causes of anemia, such as vitamin B12 or folate deficiency or renal failure and or many others. It is critically important to find the cause of the iron deficiency. Sometimes it is obvious, such as the common cause in many young people of heavy menstrual bleeding or postpartum hemorrhage, but it could be gastrointestinal tract bleeding or blood donation. Every patient needs a careful bleeding history, which remains the best test to diagnose a bleeding disorder is a good bleeding history, but also note that patients often have more than one cause of iron deficiency, such as blood loss plus a poor diet, and take a very, very comprehensive history to make sure you miss nothing. Heavy menstrual bleeding should be recognized as a common and important cause. 1/3 to half of all adolescents suffer from heavy menstrual bleeding. 1/3 of these will visit their GP in any 3-year period for help, and 1 in 20 of them will actually end up in intensive care with severe iron deficiency anemia. And there are many questionnaires, some of them very simple, such as this one, that you can ask. And if the patient answers yes to any one of these, that usually indicates heavy menstrual bleeding and the need to treat and manage that also. Furthermore, any postmenopausal woman needs a gynecological evaluation if they have bleeding, and all men and all postmenopausal women have to be considered for gastroscopy and colonoscopy, and even young people with changed bowel habits or bleeding from or iron deficiency of an unknown cause should be evaluated for potential diseases and cancers of the gastrointestinal tract. It is also important to notice how common diseases of both the upper GI tract and the lower GI tract is. In this example, you can see that patients who were referred for upper endoscopy, 9% had peptic ulcers, 4% actually had cancer, and in 33% of cases, there were significant lesions that required therapy. Now, it is very important to also realize that you cannot just do either colonoscopy or gastroscopy. Current guidelines suggest that you need to do both upper and lower, because in patients with, if you do a colonoscopy, you'll see 9% of patients will have cancer, 11% will have high-risk adenomas, and significant lesions of some kind will be found in 53%, which means that many patients might have a problem both in the upper and in the lower GI tract, so you have to do gastroscopy and colonoscopy. Why do we need to treat iron deficiency, even if there's no anemia? Well, as I said, iron is needed in every cell in the body, and iron deficiency, even without anemia, can be present with all the symptoms of iron deficiency anemia. And we call that NAID, or non-anemic iron deficiency. This slide demonstrates all the symptoms and how common they are in patients with iron deficiency, even if they are not anemic. And you can see here that this really creates a huge burden of disease on individual patients. Fatigue, exhaustion, brain fog, difficulty concentrating, feeling cold, anxious, depressed, palpitations, hair loss, dry skin, headaches, difficulty sleeping, brittle nails, and so forth and so forth. Very, very important to recognize. One should recognize the critical importance of iron in pregnancy, and as you can see here, with every pregnancy, you need an additional 1,000 milligrams of iron. You can see the mother needs about 450 milligrams to make more red cells, the baby 270, the placenta 90. A normal birth will lead to the loss of about 250 milligrams of iron. You will lose about 200 milligrams of iron through the gut and skin. And well, you also have some savings because the patient doesn't menstruate. But at the end, if you put it all together, the And one single pregnancy requires an additional 1,000 milligrams of iron. And you may ask, why is that important? Well, if a pregnant mother is iron deficient, she is going to become anemic. Postpartum hemorrhage is one of the #1 causes of maternal death, and the lower the mother's HP, the closer she is to the cliff of dying from postpartum hemorrhage, because she will not have enough red cells in the body to compensate for a severe bleed. But it's not only that. These patients also have an increased risk of infection. They produce less breast milk. There's more postnatal depression and poorer bonding between mother and baby. And also recognize that the fatigue, forgetfulness, and cravings in pregnancy are usually due to iron deficiency. For the baby, there's an increased risk of fetal death, low birth weight, growth restriction, preterm birth, and poor bonding with the mother. We also now know that there are many developmental problems that occur in babies that are born from iron deficient mothers. This study shows, or these two studies shows, that both premature babies and mature infants born of iron deficient mothers had problems in their hearing. The next one that you can see here, this is a study done here in South Africa. It was a prospective study from 20 to 28 weeks of gestation, more than 1,000 children, and children born of, in this case, of anemic mothers. If you followed them up for 2 years, it was found that at age 2, they had lower cognitive scores and lower scores on language compared to those who were not born of anemic mothers. Other studies have shown that if you follow these children up even longer, that by the age of 4 to 6, these children born of mothers that were iron deficient had slower perceptual speed, poorer motor proficiencies, problem with language, they were more fearful, more unhappy and wary, more tired, and they stayed closer to their mother during free play. Unfortunately, it didn't stop there. In adolescence, or early adolescence, it was noted that they still had slower perceptual speed, problems with memory, attention, reading, mathematics, an increased chance of repeating a grade, needing tutoring, more risk-taking behavior, more anxiety, depression, social problems, even delinquent behavior and aggression was more common in these adolescents who were born of iron-deficient mothers. The problems remained into young adulthood, where there were still problems with memory and tests of strategy shifting. And even as adults, at the age of 25, these children or these people were less likely to have completed high school, pursue further training and education, felt more detached, had more negative emotions, and generally had poorer rating of emotional health. It has been recognized that that pregnancy has different periods, some which we call sensitive and others critical. For instance, if the mother was iron deficient in trimester 1 and 2, you can still reverse any problems that might arise by giving iron in the 3rd trimester. But if the mother is iron deficient in the 3rd trimester, you have to replace the iron there and then. You cannot reverse the problems necessarily after birth. So for the sake of the baby, you have to replace it there. There's another critical period between 6 and 24 months of infancy where you have to replace any iron deficiency in that particular period. A link has also been noticed between iron deficiency and infertility, with a direct correlation between unexplained primary or secondary recurrent pregnancy losses and ferritin values. Interesting study on Iranian women have also shown that there's poor sexual function and satisfaction among reproductive aged Iranian women if they were iron deficient on every element of sexual function scoring. So how does all of this help us to decide how to treat our patients with iron deficiency? There are so many iron preparations, both oral and IV, that we can choose from. How do we choose? Well, as I said before, when hepcidin is low, such as in simple iron deficiency, you can treat with oral iron. The only challenge, of course, is that oral iron, even though it is convenient, inexpensive, and usually well tolerated, there are many patients who have lots of gastrointestinal side effects, who do not absorb it, and you have to recognize that you can't just treat iron deficiency for a month. You usually need about 3 to 6 months worth of treatment. And there are many interactions, of course, with food and medicine. So it is not obvious that this treatment will work for everybody. Also, if there's ongoing blood loss, oral iron may be inadequate. And as I say, because you have many months of treatment that you require, the total cost may even be higher than giving patients intravenous iron. There are ways to improve efficacy and tolerability. For instance, to change to a different formulation, avoiding enteric-coated or timed release formulation, which are often better tolerated but poorly absorbed. And also to notice that oral iron, especially the Fe2+, such as ferrous sulfate, can actually worsen some inflammatory bowel conditions and will not be absorbed well if patients have had bariatric surgery. Then there is also very interesting information on dosing schedule, such as these studies that have shown that if you use some oral iron supplements like ferrous sulfate, that works better if you take it every second day with better response and less side effects. There are, of course, newer iron formulations such as iron polymaltose complex as an example that can be taken with food. Sucrosomial iron, which can bypass the hepcidin pathway, and these have advantages of less side effects and usually better adherence by the patient. When hepcidin is high, as mentioned before, you need to use an alternative route because oral iron absorption is blocked. This is where we will consider IV iron or sucrosomial iron. And what can you expect? Well, so many of these symptoms will disappear almost immediately, such as cravings, this is an example here of craving for ice, bagophagia. The patient should start feeling better within days. The patient will start to respond within a week to 10 days, and you should see a clear hemoglobin increase of about 2 grams per deciliter within 3 weeks. But this all depends, of course, on your starting hemoglobin. The lower your starting hemoglobin, the longer it will take to get the patient back to target. So although in most patients you will be able to restore the hemoglobin back to normal within 6 to 8 weeks, you still have to take the iron for at least 3 to 6 months, because after the hemoglobin is normalized, you still want to build up iron stores so that the patient has enough stores for future use and especially during pregnancy. So then the question is, when do we switch to intravenous iron? Well, firstly, if the patient doesn't respond. So you have to monitor your patient to make sure that they are actually improving and that their iron levels are normalizing. Oral iron is often not well tolerated, in which case you must switch to IV iron. And then there are cases where you don't have enough time to wait for the effect of oral iron to take place, such as later in pregnancy or preoperative anemia, as we use it in patient blood management. If you sometimes need to use IV iron with erythropoietin in renal failure because these patients do not absorb iron. And of course, if patients are not able to absorb iron from other reasons, as we've mentioned before. When you treat, you do need to think in terms of the goals of therapy. What are you aiming for? Well, you want to normalize your hemoglobin, but you also want to optimize your iron stores, which is a ferritin more than 100 and a TSAT more than 20%, which usually gives you enough iron for a normal pregnancy. So in conclusion, iron deficiency is a very common health problem across the world, and you can have all the symptoms, even if you're not anemic. Anemia must be seen as the end stage, and also you must always think about the underlying cause, and understanding the pathophysiology is key to diagnosis and treatment. If you want to learn more, you're welcome to visit my YouTube channel, where there's a lot of videos on iron and iron metabolism and other things, hematology, that might be potentially useful to you.